Now, having heard a lot of very intriguing and interesting things about the problems we encounter nearly every day in our intensive care unit, with the topic AKI and hemolytic uremic syndrome, we're more moving to the rare and very rare side of things. But what I'll try and do in the next 20 minutes or so is to persuade you that you will have the odd patient that will also have the dual problem of AKI, maybe with sepsis, and at the same time, evidence of thrombotic microangiopathy. When we discuss HUS, of course, we have to discuss this in the context of thrombotic microangiopathies as a whole, and you will be familiar with what we're talking about. Endothelial cell injury and activation plus microvascular thrombi will lead to hemolytic anemia, non-immune thrombocytopenia, and organ failure. And basically, this is the triad you have as exemplified by fragmented red cells, evidence of hemolysis, non-immune thrombocytopenia, and different kinds of organ failures. Now, there are several common forms of thrombotic microangiopathy, but probably the most common one is disseminated intravascular coagulation, such as to be observed in patients with sepsis, but also in obstetric disasters, patients with severe trauma, exposed to toxins. But it's important to differentiate that from the true forms, the hemolytic uremic syndrome and the TTP. In terms of HUS, we differentiate between the STEC HUS, which is caused by Shiga toxin-producing enterohemorrhagic E. coli bacteria, and it's important to differentiate this from the atypical HUS, which summarizes basically all the non-EHEC associated causes. And as I will show you in a minute, we have as a problem here an underlying complement dysregulation, and these patients have the tendency for disease recurrence, and basically treatment will have to be on a long-term basis. In TTP, you will be aware that there is a deficiency of the ADAMTS13 metalloproteinase that leads to the formation of ultra-large von Willebrand factor multimers that will be binding platelets and forming blood clots in the microvessels. And in terms of distinguishing those two entities from DIC, as you will have it in patients with severe sepsis, in general, the DIC will have a patient presenting with coagulation abnormalities such as prolonged PTT and PT, an increase in fibrin split products, and low levels of anticoagulant factors. Whilst in TMA, you will find schistocytes in blood smear, hemolysis signs, fever, and organ failure or impairment. But all these things I put in gray color here can also be observed in patients with DIC. But the distinguishing criterion mostly is that coagulation times are usually normal in patients with TMA, and that could serve as the primary distinguishing criterion. Now, if we talk a bit about the pathophysiology of TMA, it's important to distinguish between some extrinsic versus intrinsic factors. There are some conditions associated with TMA that might be the precipitating events, of course, systemic infections, but also certain medications, and particularly compounds interacting with the VEGF pathway, malignancies, immune complexes, malignant hypertension and pregnancy, but also big surgery or big trauma. All these lead to endothelial damage and occlusion, subsequently to microinflammation, increased permeability of the vessels, thrombosis, and mechanical hemolysis. And ultimately, we'll find the clinical and laboratory signs of platelet consumption and organ failure. However, there is some direct causes that predispose or cause the thrombotic microangiopathy. And as I already mentioned, it's uncontrolled complement activation, such in HUS, abnormal cleavage of the von Willebrand factor with ADAMTS13 deficiency in patients with TTP, or the Shiga toxin-producing E. coli in STEC use. Important to note, those patients have very overlapping clinical presentations despite different underlying mechanisms. And this is again shown in this schematic sketch. In STAC HUS, the bacteria produce the Shiga toxin, which will both damage the endothelium but also activate complement and platelets and then form these clots. In atypical HUS, the genetic complement system mutation leads to chronic uncontrolled complement activation. There might be patients that have a certain threshold of ongoing smoldering complement activation, and by precipitating event, this is then going to be manifested. And here, as opposed to the mechanism of the TTP with the ultra-large transvirulent factors, which bind platelets and form blood clots. As I mentioned, atypic HUS is caused by chronic complement activation, and this will involve basically all the elements of the streaming blood, like the endothelial cells, swelling and disruption of the endothelial cell membranes, will lead to lysis and fragmentation of the erythrocytes, activate leukocytes, and also activate platelets and aggregate them. And at the end of the day, the clinical symptoms will be anemia, thrombopenia, and increased procoagulant activity. In the past couple of years, we have understood that in many patients, atypical HUS is a genetically determined disorder of the complement system. It's important to note that you can find that not in all patients presenting with a clinical picture, but just in about 50 to 60% of those patients. And this is a variety of known mutations so far. Most prevalent is mutations regarding complement factor H, but it's also important to understand that we can have loss of function mutations in regulatory genes, but we can also have gain of function mutations in certain effector genes. The proposed mechanism, as I briefly mentioned, is a triggering event which will then tip the balance and lead then to the openly manifested disease. Now, in clinical terms, how should we go on to perform a differential diagnosis of TMAs? And this is basically summarized in this slide. If you have a patient with low platelet counts, and at the same time, signs of microangiopathic hemolysis, and either neurological symptoms, renal impairment, or gastrointestinal symptoms, you should evaluate the activity of the proteinase MTS13 and also do a Shiga toxin AHAC test, which you usually get more quickly than this. And in general terms, so data from epidemiological studies suggest that if the patient has a higher platelet count than 30,000 and or a serum creatinine, which is strongly elevated, that makes the diagnosis of TTP rather unlikely, because these patients will mostly have very low platelets and less reduced kidney function. However, if the patient is proven AHAC positive, then the diagnosis of STAC HUS is highly likely. If you have a very reduced, lower than 10% activity of the proteinase, the diagnosis of TTP can be made. And if this is true and the patient has still above 10% ADAMTS13 activity, then the diagnosis of atypical HUS can be made. It can be complicated in the clinical routine to identify such patients, and I will briefly give you one example of a female patient, 43 years of age, that last year presented in our hospital. She was first admitted to a smaller hospital with subacute onset of disease with gastrointestinal syndromes, abdominal cramps, but also fever and shivering. That was when her partner did call the emergency services. When she was admitted, she had fever, tachycardia, low blood pressure, and strongly elevated inflammatory markers. And already they found platelets decreased to 45,000 and just about normal serum creatinine. Antibiotic therapy was initiated with ceftriaxone, and because of the low blood pressure, the patient was admitted to ICU. Unfortunately, she developed a further deterioration of her clinical situation, developed sustained anuria, and platelets dropped further when she was then admitted to a tertiary service to our university hospital. This is the labs when she was admitted. Signs of AKI with a creatinine of 2.2, inflammation markers, elevated CRP, somewhat increased liver enzymes, but a strongly elevated lactate dehydrogenase, signs of anemia, leukocytopenia, and also profound thrombocytopenia with only 10,000. Coagulation parameters were also changed with a PTT that was prolonged. What we do in such cases is when we suspect sepsis, we do a DIC score. You will be familiar with this, platelet count, fibrinogen, prothrombin, D-dimers. At that time, she just hit the score with 4 points, and that is probably only a compensated non-overt DIC, so that would not be a good explanation for these very, very low platelets. And that's when we looked at fragmented red cells, and there were more than 5% of fragmented red cells. At the same time, Shiga toxin was found negative, so the suspected diagnosis was TTP or HUS complicated by sepsis, and the patient was then treated according to sepsis guidelines, and on the next day, when she remained anuric, put on intermittent dialysis, having in mind that with 10,000 platelets to start with, she would not be the ideal candidate for a continuous regime. We did daily plasma exchange for 5 days, but this had no effect whatsoever on platelet counts. Then we received the message that ADAMTS13 levels were normal, but in blood cultures there were meningococci. So we thought, okay, mishandled it, patient has a fulminant septic shock, and we discontinued plasma exchange, transfused platelets, and put her on continuous veno-venous hemodiafiltration. In the next couple of days, there was marked clinical improvement, vasopressors could be discontinued, a weaning from ventilator went well, but the patient remained anuric, platelets remained below 20,000, and fragmented blood cells remained above 5%. And then we thought, well, maybe there is still something more to it than just sepsis, and restarted plasma exchange, what finally led, after 8 treatments in total, to an increase of the platelets to above 80,000 and a gradual improvement also of kidney function, and the patient did not require further renal support. After she was discharged to the nephrology ward, a kidney biopsy was done, and the kidney biopsy gave the full picture of thrombotic microangiopathy with clots in the small blood vessels. So in retrospect, the diagnosis was made of atypical HUS complicated by sepsis. Now, what treatment options do we have? Over the years, and especially before we had a better understanding of the underlying dysregulation of the complement cascade, HUS has been managed mostly using plasma exchange and or plasma infusion. However, many data suggest that there is only a limited effect of plasma exchange therapy in about only 50% of the patients really responding with improving of kidney function. And a large number of these patients, about 1/3 of pediatric patients and 2/3 of patients with, of adult patients with atypical HUS, progress to end-stage renal disease or even die. Now, for a couple of years, we have a causal therapy in the form of eculizumab, which is a terminal complement inhibitor, which is in the meantime approved to treat both adult and pediatric patients with HUS. It's an antibody that binds to complement protein C5, thus blocking its cleavage and preventing the production of the terminal complement component, C5a, and thus the formation of the membrane attack complex, C5b-9. And by doing that, it reduces the endothelial damage and also the thrombosis and subsequent renal injury. It is also shown to be beneficial in patients with complement-mediated HUS due to autoantibodies to complement factor H. And the suggestion is that patients with the diagnosis of atypical HUS should receive that treatment as the first-line treatment in the light of that plasma exchange is just working in about every second case. I briefly show you one of the first studies that have been using the compound in children and adults who were at least 12 years of age. It was basically two small groups of patients in a phase 2 trial. In trial 1, it was patients with low platelet counts and renal damage, and in the trial 2 was patients with a stable platelet count and prior therapy. What you can see here is a few weeks after initiating the therapy, there was an increase in the platelet counts that remained stable over the treatment time. And importantly, that's the trial group 1, trial group 2. In the pre-treatment period, the patient had no change in the GFR, but after the treatment, in the treatment period, GFR increased by 20, 25, or even 30 ml per minute. And importantly, 4 of 5 patients who already were on dialysis could stop dialysis. So it appears also to be effective in patients who had advanced renal disease. There is, of course, some risks and adverse events possible. Patients should receive vaccinations for meningococci, but also for Streptococcus pneumonia and Haemophilus, because they are at risk to develop serious infections with these species. And there is an annual rate of about 0.5% of meningococcal infections that can be observed. And recently there was a KDIGO controversies conference that's just published a couple of weeks ago in Kidney International. And the conclusion is basically that all patients with a clinical diagnosis of primary atypical HUS are eligible for treatment with a complement inhibitor. You can use plasma therapy if the antibody is unavailable. And of course, plasma exchange should be considering for anti-factor H positive HUS and in the emergency care of critically ill patients with severe TMA before the distinction between the different forms of TMA has been made. There is a risk if you delay the onset of eculizumab may lead to non-optimal therapeutical outcomes. Of course, there's a list of supportive care measures that are recommended. I think that's pretty obvious that patients should receive red blood cell transfusions when clinically indicated, for example, when the hemoglobin level, specifically in children, is below 6. And also platelet transfusions if the patients have significant clinical bleeding. This might occur if platelet count is 10,000 or below. And of course, the other measures are what you do in your management of ICU patients, fluid electrolyte management, stopping nephrotoxic drugs, etc., etc. So at the end of the day, and that's going to be my last slide, I think it's important to think about it. If you have a patient with signs of hemolytic anemia, non-immune thrombocytopenia, and AKI, then you should think about thrombotic microangiopathy. And then if it's diagnosed as atypical HUS, you have a course of therapy, anti-complement therapy with the eculizumab. Thank you very much.